What's up, Ninja Nerds? In this video today, we're going to be talking about the introduction to acid-base disorders. Before we get started though, please, if you guys do like this video, you benefit from it, you learn a lot from it, you enjoy it, please, the best way you can support us is by subscribing. Also, hit that like button, and if you like, put a comment down in the comment section. Also, down in the description box, we're going to have links to our social media platforms, as well as our Patreon. If you guys want, we're going to have comprehensive notes that we're continuously adding to that'll supplement this video. So go check that out, as well as some nice illustrations that Kristen's also worked on too. So go check that out. All right, Ninja Nerds, let's get into it. All right, Ninja Nerds, so when we talk about acid-base disorders, we should have a basic understanding of what makes something acidic, what makes something alkaline, and the terms that get thrown around a lot. One of the big ones is acidosis and alkalosis. So we need to have an understanding of what these things mean. So what does acidosis mean? Acidosis is the process by which protons are produced in a large amount. There's an increase in the proton production. So that's all it is. So acidosis is there's some process, which we'll talk about what are the processes by which this can happen, by which there's an increase in the proton production, or just the amount that it's actually being present with inside of the body, the extracellular fluid. So the process by which we increase our proton production is called acidosis. Alkalosis is just the opposite. It's the process by which there is a decrease in the proton production or concentration, or there's just less protons with inside of the plasma or the extracellular fluid. And there's many different reasons for these. Now, what's important to know is that acidosis, the process by which there's an increase in protons, can cause the blood to become more acidic. How do I know that? There is a formula that we utilize a lot. pH equals the negative log of the proton ion concentration. And it's just an inverse relationship. As you have high proton concentration, that lowers the pH. When you lower the pH in the blood, that makes the blood acidic, and this is called acidemia. So the question is what is a particular point at which the pH is now considered to be acidic within the blood? That's a great question. Normal pH is between 7.35 to 7.45. So if we're having a lower pH, we're less than 7.35 within the blood, that's acidemia. So it's a pH less than 7.35. Take the opposite. We now have a pretty straightforward thing here, right? A decrease in the amount of protons within the body, some process by which that happens. Utilize our good old equation, pH equals the negative log of the proton ion concentration. Simplistic way is it's inverse, is you have decreased protons that increases the pH. As you increase the pH within the blood, this makes the blood more alkaline, and this is called alkalemia. What's the point at which the blood is now alkaline? What's normal pH? 7.35 to 7.45. So it has to be greater than the upper limit of normal, which is greater than 7.45. Okay? So very important understanding here is that acidosis and acidemia, alkalosis and alkalemia are not technically the same. They're commonly sometimes thought that they're interchangeable, but acidosis is the process by which you make the pH lower in the blood. Alkalosis is the process by which you make the pH higher within the blood. Now the next thing is that we've talked a lot about protons influencing the pH of the blood, but there's also two other molecules that we have to talk about that influence the pH. There's this equation. It happens all the time in our body. Our bodies are constantly undergoing metabolism, breaking down glucose, oxygen, and producing CO2 and water. So this is a constant byproduct of cellular metabolism. So when CO2 and water combine, there's an enzyme, if you guys really want to know it, it's called carbonic anhydrase. It's present in certain cells and membrane borders that converts it into carbonic acid. Carbonic acid is a very weak acid and dissociates into protons and bicarb. The two molecules that I want you guys to think about here is CO2 and bicarb. We talked a lot about protons, right? Up there, let's talk about these two. These two have a very significant, profound effect on the pH as well. How do we determine that? This annoying equation that you guys probably thought you would never have to see again since general chemistry, the Henderson-Hasselbalch equation. Henderson-Hasselbalch equation says if you want to determine the pH based upon the bicarb and the CO2, not just the proton concentration, you can use this equation. We don't need to know all this. let's make our lives really, really simple. Let's not worry about numbers and math and all that stuff. Let's just do this, and you'll see how much easier it is. Get rid of the pKa, get rid of the log. We don't need that. pH is equal to the bicarb concentration divided by the CO2. Now we got to be a little bit particular here. Bicarb is in a particular concentration called milliequivalents per liter, right? Where CO2 is recorded on a pressure. So it's usually millimeters of mercury. So I can represent this in concentration, but if I really want to be particular, which I should be, I should put partial pressure of CO2. This is a modified Henderson-Hasselbalch equation, and it prevents us from having to do any math and just use logic. So let's just do that instead. All right, so now we have this. This is going to help us big time. And I'll show you how it will help us to determine what the primary disorder is. Is it a respiratory disorder or is it a metabolic disorder? So let's talk about them down here. The first one that I want to discuss here is a respiratory disorder that causes the pH to go low. That means it's an acidosis, and the cause of this acidosis is a respiratory problem. So we call this respiratory acidosis. So think about the causes of respiratory acidosis. It's really straightforward. It's not too hard to think about. If my brain is not firing, it's not sending signals, that's going to cause a problem. My respiratory center within the brainstem, if it's not firing, if it's depressed. So one reason could be that there is CNS depression. And there's a lot of different causes for this. The other thing is that there's a nerve problem. The nerves that are going to the muscles are damaged in some way, and they're not sending signals to those muscles, my diaphragm, to contract. Or the muscles are damaged themselves. So there is a neuromuscular disorder. Or there's a problem where my lungs are having some type of obstruction and I'm not able to breathe CO2 off, and things like COPD or obstructive disorders. So some type of obstructive lung disease. All of these things would cause less CO2 to be exhaled out of the body. If less CO2 is exhaled out of the body, what happens to its concentration within the blood? It builds up. If the CO2 concentration in the blood builds up, don't worry about this whole equation up here and all that stuff. Just use this simplified one. Let's use logic here. Keep the bicarb constant. So we're not even going to focus on this one. Just put that like, it's constant. But the PCO2 is what? It's elevated. If we use this reaction, we just put like N here for a constant. pH, if we use this simplified equation here and we just say that CO2 is increasing, what happens to this number, the pH? If this was 1 and you increase the lower number, it's going to do what to the pH? It's going to lower the pH. So the pH in this scenario would be low. So if we say this, the pH will be low, pH due to what? Due to high partial pressure of CO2. And we just did it with that modified Henderson-Hasselbalch equation. Let's think about the other scenario. You have an alkalosis. The pH is high, but it's due to a primary respiratory disorder. What is that called? Respiratory alkalosis. Okay, so respiratory alkalosis, let's think about the causes. Keep it really, really simple. Something that's causing the respiratory centers to overfire. And there could be many different reasons for this. Let's just call that CNS hyperactivity. To label a couple things here, if someone's really anxious, if someone's having a fever, if someone is in pain, if someone's taking salicylates, sometimes sepsis, a bunch of different things, they stimulate that respiratory center and it overfires, sends more signals, increases your respiratory rate, and you breathe off more CO2. The other situation here is that if somebody is having hypoxemia, and what hypoxemia is that there is low oxygen delivery to your tissues. So let's say that someone is having pneumonia and they're not getting oxygen to cross over that infected area. Or they have a lot of edema, pulmonary edema. Oxygen is not crossing that area where there's a lot of fluid there. Or they have a PE, a clot, and there's not, even though you have proper maybe ventilation, blood can't get to that area of the alveoli to put oxygen into the blood. Either way, what happens? What do you think you would naturally do if your oxygen levels in the blood are low? Breathe more. Because if you're breathing more, you're going to breathe in more oxygen, hopefully. But what's the consequence of that? As you bring in more oxygen, you breathe off more CO2. So if you're either increasing your stimulation, or whether it's due to some CNS stimulation or because of a hypoxemic drive, you're blowing off more CO2. And what happens then? If you blow off more CO2, the CO2 concentration within the blood will decrease. Use our simplified Henderson-Hasselbalch equation. This is a constant. What happens to the PCO2? It lowers. Use this equation. What would this tell us? If this number is lower, the denominator, then the pH will go up. So this will tell us that the pH will increase because due to a low partial pressure of CO2. Pretty straightforward, right? All right, next thing. Let's say that we have an acidosis, but it's due to not a respiratory problem, it's a metabolic problem. And there's so many different reasons for this. We're not going to get into crazy detail. But if there's an acidosis and it's not due to a respiratory problem, it's due to a metabolic problem, this is called metabolic acidosis. So a metabolic acidosis, the problem is that your body is either retaining a lot of protons, you're not excreting the protons, or you're losing a lot of bicarb. Those are the two primary reasons. So let's think about this. Let's not worry about the protons, and let's think about the bicarb in this scenario. What's happening to our bicarb? It's lowering. Use your equation here. If we keep PCO2 constant, and we do what to our bicarb? We lower the bicarb. If the bicarb decreases, what happens to the pH then? The pH will decrease. Because again, the top number is going to determine that. So if this happens, your pH will decrease due to low bicarb. Okay? All right, so before we start talking about some of the causes for metabolic acidosis, we know that it's usually due to an increase in proton concentration and a decrease in bicarb. There's something else that we have to talk a little bit about real quick, and that's something called an anion gap, because that can actually separate our acidoses into two types of flavors. So an anion gap you can determine based upon this equation. So anion gap, we'll put it as AG here, is equal to the extracellular cations. The most abundant is sodium. We don't really care about potassium because it's mainly intracellular. The next one is you're going to do what? You're going to subtract this from the pertinent anions within the extracellular fluid. And this is going to be chloride and then your bicarb. And what happens is the remaining amount that makes up this gap, so you're taking sodium, you're subtracting the chloride and the bicarb, the remaining amount is the anion gap. And the anion gap is a measure of particular types of organic acids that we don't really include in this equation. If the anion gap is less than 12, it's considered to be a normal anion gap metabolic acidosis. We sometimes refer to that as a NAGMA. If the anion gap is greater than 12, then that is called a high anion gap metabolic acidosis, but we just call that AGMA. So that leads to the whole question here is what are the different causes for someone having a normal anion gap metabolic acidosis or an anion gap metabolic acidosis, because they're causing an increase in proton in the blood or a decrease in bicarb. Without going into too much detail, because we'll go into these in more detail in individual videos, let's use a nice little mnemonic to help us to remember this. So for AGMA, anion gap metabolic acidosis, you can remember the mnemonic mud piles. And the causes behind this is usually due to methanol poisoning or ingestions, uremia due to significant kidney injury or renal failure, diabetic ketoacidosis, propylene glycol ingestions. I is going to be for isoniazid, which is one of the drugs that you give in tuberculosis. L is for lactic acidosis. E is for ethylene glycol. And S is for salicylates, and this is just your aspirin. The other type of metabolic acidosis, which causes an increase in protons or a decrease in bicarb, that has a normal anion gap, less than 12, is called a NAGMA. And the causes for this can be remembered by the mnemonic hyperchloride emia. And this is sometimes whenever you give a lot of people like a lot of normal saline or hypertonic saline. And another one you can remember is if you really want to add this on, I'm not going to write it out. It's called hyperalimentation. All that means is you're giving them a lot of food through their alimentary canal. What would be a condition where you do that? Where you're giving somebody TPN. So sometimes you can also add into this TPN, which is called hyperalimentation. The other one is A. Right, so in A, this problem is an issue with acetazolamide. There's a drug called acetazolamide. And acetazolamide can actually cause a lot of bicarb loss from the kidneys. The other one is called a renal tubular acidosis. And we're not going to go into a lot of detail because there's a bunch of different types of these. And they can either lead to kind of a loss of bicarb as well. All right, the next one is actually going to be diarrhea. In diarrhea, you lose a lot of bicarb, and that's one of the reasons for acidosis. The other one here is called a ureteral diversion. Sometimes if someone has a connection between their ureter and between a part of their GI tract, they can actually spill a lot of that chloride out as well. And then the last one here is a pancreatic fistula. And again, you lose a lot of bicarb through that way as well. Okay, so these are some of the big reasons for someone developing a metabolic acidosis. Primary thing to remember is that there's a low bicarb, high protons. And it could be due to an anion gap that's elevated or an anion gap that is normal. Okay? The last type of primary disorder is a alkalosis, but it's not due to a respiratory disorder, it's due to a metabolic disorder. So this is called metabolic alkalosis. Now, metabolic alkalosis, if we utilize our nice little, modified Henderson-Hasselbalch equation here, what would we say? The PCO2 is going to be constant, but the bicarb, what happens in alkalosis? That means that the protons are lowered and you have a lot of bicarb. Bicarb is our base, right? So if there's a lot of bicarb, it's going to make the blood more alkaline. So this is going to be increased. Use this simplified equation. If the top number is high, pH is going to be high. So in this condition here, pH is going to be high due to a what? A high bicarb, okay? Or a low proton concentration. Now, for these situations, there's a bunch of different causes. To keep it relatively simple for us, let's kind of use the mnemonic vomit, okay? Vomit is, guess what the first one is? Vomiting. When you vomit, guess what you spill a lot of out? Protons. There's a lot of hydrochloric acid. You're spilling a lot of acid. You're losing acid. O is you're actually overcorrecting somebody on the vent. So overcorrection of what's called hypercapnia. And we're not going to go into great detail of this. We'll talk about it in an individual video with the respiratory system and metabolic system, but overcorrection of hypercapnia. The next one here is M, and this is remembered by mineral corticoid excess. And what is this? This is just whenever somebody's producing a lot of aldosterone, right? And there's a lot of different conditions. One of the big ones is Conn syndrome, right? The other one is iatrogenic, giving them some type of bicarb. So iatrogenic, one of the common reasons is that we would give someone sodium bicarbonate. And you could do this for a bunch of different reasons. You're trying to preserve their kidneys for contrast-induced nephropathy, or they have kidney failure. So sometimes if you give them sodium bicarbonate, that could also be a cause there because you're giving them bicarb, increasing their bicarb. And the last one is that you have a total volume loss. And this could be in a bunch of different situations. So if someone's dehydrated, they're losing blood, they're having laxative abuse and they're pooping out a lot of their actual chloride, or another situation would be that they are taking a diuretic and they're just losing a lot of volume that way. So these would be some reasons why someone could develop metabolic alkalosis. So this covers kind of our basis and our primary disorders. Now let's talk about the complications of acidosis and alkalosis. So we should have an understanding of why it's important to know about acidosis and alkalosis. Like, what does it do to us? Like, what's the problem? Why should we be so scared of it? It does have a lot of, problems and complications that it can cause. And the particular organs that you want to remember, big ones, is the heart and the lungs, your central nervous system, and then there's some metabolic effects that we'll also talk about that can become very problematic as well. So let's say over here on the left side of this, let's talk about what acidosis can do to these organs. Okay, and then over here on this side, we'll just compare and we'll talk about what alkalosis can do to these organs. Okay, same thing. So acidosis, when there's a lot of protons, what it loves to do is really affect the myocardium, the contractility of the myocardium, and decrease the contractility of the myocardium. If you decrease the contractility of the myocardium, you decrease stroke volume. If you decrease stroke volume, you decrease cardiac output. And if you decrease cardiac output, you decrease your blood pressure or your mean arterial pressure. The other thing it does here is it also acts on the smooth muscles within your arterioles, okay? And when it acts on the smooth muscles in your arterioles, it actually causes them to dilate. So it causes vasodilation. If you cause vasodilation, what does that do to the diameter? It increases the diameter of the blood vessel, and that decreases resistance. If you decrease your total peripheral resistance, what does that do to your blood pressure? It lowers your blood pressure. The cumulative effect of decreasing cardiac output and decreasing the total peripheral resistance will have a cumulative effect on causing hypotension. And then sometimes this can even lead to shock. So important to be thinking about that. The other thing is with acidosis, it can cause a lot of arrhythmias, like reentrant kind of tachycardias. And one of the big things it does is it agitates that myocardium and can lead to VTAC. Okay, so a lot of VTAC can happen here as well. There's one more thing I thought was really interesting when I was researching this, is that when you have a lot of acidity and someone's becoming hypotensive, what do you give them? Well, you give them fluids. What's the next thing you do? You give them pressors to cause those vessels to clamp down so that they're not becoming hypotensive. And people who have really bad acidosis, they're resistant to pressors. And so that's another interesting thing, is that sometimes if you have to go up on the pressor dosage, think about, are they acidotic? So sometimes a big one to remember, I thought this was really interesting, is that it can cause resistance to vasopressors. All right, cool. Now, compare that with alkalosis. There really is no superb effect on the contractility, so we're not going to talk about that one. So no real big effect here for the contractility aspect, but there is an effect on the total peripheral resistance. Just do the opposite here. It actually causes arteriolar vasoconstriction. That narrows the diameter, increases the total peripheral resistance. So the next thing here is heart rate. You'd probably say, oh, well, it's going to decrease the heart rate. It actually doesn't. It still agitates the myocardium and can cause those actual the tissue cells to fire, those myocardial cells to fire a little bit faster. And so it actually can cause some pretty nasty arrhythmias, particularly VTAC and even severely VFib. Sometimes even SVTs as well. So we'll even put that down. Sometimes it can even trigger some SVTs. So either way, these are big things to remember for the consequences or complications of acidosis and alkalosis on the cardiovascular system. What about on the lungs? It's really simple. If someone's acidotic, what is the goal? That means that they have a lot of CO2 in the blood. You want to breathe all that CO2 off. So breathe that CO2 off by increasing your respiratory rate. What's the complications of that? If you're breathing all the time, what's going to happen to your muscles? You're just going to get fatigued and you're going to get really weak. And so this can cause an increased work of breathing. We'll put that as WOB. And then what this can do is this can lead to increased fatigue. And sometimes if this isn't reversed, it can cause the patient to go into respiratory failure. So in alkalosis, think about this in the opposite scenario. In someone who has alkalosis, they have low CO2 within the blood. What are you going to want to do? You're going to want to build that CO2 up. How do you build the CO2 up? You lower your ventilation rate, you lower your respiratory rate. If I lower my respiratory rate, what's the problem with that though? Yeah, I might build up the CO2, but guess what? I'm not bringing in oxygen. Because remember, with tidal volumes, yes, you could breathe out the CO2, you could retain CO2 with less respiratory rates, but you're not going to bring as much oxygen in. And this can lead to hypoxemia. And this can become a problem, okay? The next thing you got to think about is the metabolic effects. What I like to remember is that protons and potassium kind of go hand in hand. So in this situation in acidosis, what happens is there is going to be a lot of protons, okay? When there is a lot of protons, the protons will want to shift. When there's a lot of protons, they'll want to shift from the extracellular outside of the cell into the cell. And whenever they do that, there's a little pump here that also transports potassium out. And so whenever the protons are brought into the cell, you push potassium out of the cell. What is that going to do? Yeah, you may increase this reaction here. And what is that going to do to the potassium? It's going to increase the potassium. If I cause an increase in potassium, what is that called? Hyperkalemia. And hyperkalemia can be very bad and cause a lot of arrhythmias. The other thing is, this can actually, a lot of these protons can affect your pancreas too, believe it or not. Particularly the hormone made by your pancreas. You know your pancreas makes a particular hormone called insulin. And what insulin does is it works on tissues and tries to be able to perform a lot of metabolic functions to lower your blood glucose levels. So let's pretend here I put like a tissue cell right here. And insulin's gonna act on that tissue cell. Guess what the protons do? They affect and alter the activity of insulin being able to work on these tissue cells. And so now insulin can't exert its full effect on these tissue cells. And what is that called? That's called insulin resistance. And so what would happen to the person's blood glucose levels? They would go up, right? And so that's another thing to be thinking about. Compare that over here. So just use the opposite effect here. Potassium, magnesium, they kind of also shunt a little bit too. So for this situation, think about the same scenario. If there's less protons, less of those protons will be shunted into the cell, less potassium ions will leave the cell. So what happens to the potassium outside? The potassium level outside the cell will decrease. The same kind of mechanism, but to a lesser degree, can happen with magnesium. So the same reaction here can also happen with magnesium. So if less protons are going into the cell, less magnesium will be leaving the cell. And so the magnesium levels within the blood will also drop. This last one is a little weird, okay? There is a protein that's made within our blood called albumin. Okay, so here's our albumin. Albumin has a lot of like negative charges around it, and it loves to bind onto protons, okay? But if you have alkalosis, how many protons do you think you'd have? Less protons. And so some of these protons will bind onto this albumin but leave a lot of negatively charged spaces left over. So who do you think is going to want to bind onto that and neutralize that negative charge? Calcium. And so calcium will bind, a lot of that will bind onto these negative charges, and the calcium that's actually free or circulating in the blood, the ionized calcium, let's actually be really specific here. Let's put ionized calcium. The amount of it's freely circulating is low because a lot of it is bound to albumin. All right, cool. The last thing that you guys need to remember here is with respect to the central nervous system. The effect is pretty much the same here, where if you have a lot of acids, what that does is that really affects the cerebral volume, like cell regulation. And what it does, it can lead to a lot of an altered mental status, and particularly even lead to coma, okay, if there's a lot of acids there. And the opposite, if someone has alkalosis, it also can lead to an altered mental status, but it can also cause the neurons to be a little bit more agitated and fire a little bit more than they should. And if they're firing a lot more than they should, what is the condition in which neurons are firing erratically and not under control? Seizures. So sometimes this can trigger seizures or tetany. But again, it can also lead to coma. So big consequences if acidosis and alkalosis are not corrected. Now, we can try to correct this by giving certain drugs or treating the underlying disorder, but our body is so beautiful that it does something to try to fix this on its own if it can. And this is called compensation. Your body will try to compensate for this acidosis and alkalosis. How does that happen? Let's talk about that. All right, so let's talk about these compensation mechanisms. So how our body tries to deal with an acidosis or alkalosis kind of scenario on its own. All right, so let's say that we take the first situation here where we have someone who is in respiratory acidosis, okay, respiratory acidosis, and they're gonna try to compensate. Now, acutely, how they'll compensate is that the buffer system, that bicarbonate carbonic acid buffer system, will kind of try to kick in and buffer it acutely. That's a pretty quick reaction, but it's not gonna produce a very significant change in the pH. So what happens is our kidneys are going to be the primary way that we try to compensate when there's a respiratory disorder. The problem is, though, When the kidneys compensate, it takes a decent amount of time. So what will happen, and whenever there's high CO2, what does that do to the pH? Think about it, right? It makes the pH do what? It drops the pH. So what happens is this signals our kidneys, and our kidneys will take some time. So I want you to remember that this mechanism by which our kidneys compensate takes a long time. It's not quick. It can take hours to days, sometimes even longer than that. How would we deal with this? Well, think about it. Think about it really simply. If your pH is low, how would your kidneys try to deal with that? Well, think about it. If the pH is low, let's think about the two ions that we haven't talked about here, which also influence the pH, protons and bicarb. If I want to do the opposite, which is increase the pH, what will I do to my protons? I'll try to excrete more protons in the urine, and I'll try to reabsorb more bicarb into the blood. That makes sense, right? The problem is, though, is that this takes a decent amount of time to occur. But once the person starts to compensate, and let's say that they have a respiratory acidosis, a chronic one, they may also have a high bicarb, and that comes into the ABGs when we interpret them. So big thing to remember there, kidneys compensate for respiratory acidosis by excreting protons and retaining your bicarb. Okay? Let's go to the next situation here. Next situation here is we have a respiratory alkalosis. So in a respiratory alkalosis, what's the problem? You're building, what's happening to the CO2? It's low, right? So you have low CO2 within the blood. If there's low CO2 within the blood, what does that do to the pH? You use that equation, right? Low CO2 will do what to the pH? It'll increase it. So this is going to increase the pH. How do we deal with this other than the CO2? We deal with it via the protons, and we deal with this via the bicarb. And again, who deals with this over a long period of time? Your kidneys. It takes some time. Your blood will try to buffer it acutely, but it's not going to produce a significant change. So how will we change this? Think about it. pH is high. We want to increase the pH. So what will happen to the reabsorption of bicarb? Are we going to reabsorb as much bicarb as we usually do? No. Decrease your bicarb reabsorption. What about the proton excretion? Are we going to excrete as many protons? No. You don't want to. You want to try to retain some of those protons. So retain the protons a little bit by not excreting as many of them. If there's less protons that are excreted, more will kind of build up in the blood. That'll lower the pH. If you're reabsorbing less bicarb, less alkaline or less base within the blood, that's also going to drop the pH. Okay? Next situation here. You have a person who is in metabolic acidosis. And the only reason I say this is because I can see that the protons are going up, right? Quick, easy way. And I have my kidney here. So metabolic acidosis, okay? So when someone's in metabolic acidosis, what do I know? Look at our bicarb using our Henderson-Hasselbalch equation. The bicarb is low. What does that do to the pH? Lowers the pH. So if I lower the pH, what is this going to do? What happens is that this stimulates respiratory centers. It stimulates your central nervous system. And then your central nervous system will go and stimulate an increase in what? Your respiratory rate. Why? Because if you increase your respiratory rate, what are you going to do? Let's say I increase my respiratory rate. I'm going to breathe off more CO2. If I breathe off more of that CO2, how much of the CO2 will be left within the bloodstream? Less. There should be less because I'm breathing most of it off. So CO2 within the blood should be low. Utilize our equation here to see the change. If our CO2 is low, what happens here? Bicarb, let's just not worry about that right now. Kind of pretend it's constant for a second. And your CO2 is dropping. That's your compensation. What happens to the pH? It will go up. Your problem was an acidosis. You're trying to change it by getting rid of that CO2 and making the blood a little bit more alkalotic. So this would be the compensation mechanism, is by getting rid of more CO2, which causes the CO2 levels within the blood to drop. All right, so the last scenario here is going to be metabolic alkalosis. The only reason I can tell you that is I can see here that my protons are going down. Quick, easy way to know that this is an alkalosis. And then I have my kidney here and not my lungs that are the problem. So metabolic alkalosis. In this situation, right, I have less protons, I have more bicarb. Use our little trusty equation here. Bicarb goes up, what happens to the pH? the pH will also go up, right? So if the pH is going up, what will this do to your respiratory system? Well, it's telling you that your pH is really high. I don't really want to do anything to my CO2. I don't want to breathe it off, right? I actually kind of want to retain that CO2. So instead of me stimulating the respiratory center like I did here, I'm actually going to inhibit the respiratory center so that I don't actually stimulate the muscles that are going to be controlling my breathing as much. So I'm going to lower my respiratory rate. If I lower my respiratory rate, I don't breathe off as much CO2. Instead, a lot of that CO2 will build up within the bloodstream. And as the CO2 builds up in the bloodstream, use our little trusty equation here, what happens? PCO2 goes up. What happens to the pH? It goes down. And that is how we try to compensate, because we try to retain CO2, which makes the pH go down because originally the pH was high. The big thing to remember here is that whenever your kidneys are trying to compensate, that takes a long time. But whenever your lungs are trying to compensate for a primary metabolic disorder, this is a short amount of time. This can happen in minutes. Okay, so remember that this is a short amount of time. It doesn't take near as long as the kidneys do to compensate for the primary disorder. So now that we understand the different primary disorders, the complications, the compensation mechanisms, let's determine how we can interpret an ABG, and let's do some practice problems. All right, engineers, so we've built up a pretty good foundation up to this point on kind of like understanding the basis of acid-base disorders. So what I want us to do is, let's say that we get an ABG, because you guys get these questions a lot, whether it's your nursing school, PT school, PA school, medical school, you get these questions and you have to be able to interpret ABGs. I'm going to take you through the easiest way that when I look at ABGs on a daily basis, how I interpret them. So the first thing that we do is we have to have an ABG, right? Comes up and you get your pH. I need to determine based upon that pH if there is an acidosis or an alkalosis, but particularly, right, if the pH is low, it's acidemia, and if the pH is high, it's an alkalemia. So first thing I look at is this pH less than 7.35? Because if that's the case, this is an acidemia. And if the pH is greater than 7.45, then that's a alkalemia. Now you guys, here's something really interesting. Let's say that you check the pH and it's normal. You'd probably be like, oh, there's no acid-base disorder, just move on. That's not always the case. There can be what's called compensation that we just talked about. So just because the pH is between 7.35 to 7.45, it still may be abnormal. There still may be an abnormal disorder present, and you have to still go through these steps to make sure that there's not an actual abnormal disorder with a compensation mechanism present. So that's the first thing I look for. What's my pH? After I look at my pH, I look at my PCO2. Now the PCO2 is really, really important because this is going to help me to determine if this is a respiratory disorder or a metabolic disorder. So I like to use my equation that we had before. So you can remember pH is equal to the bicarb divided by the PCO2. So the first thing I want to look at is what's the direction of my PCO2? And how do I remember that? Let's do this in two ways, right? I have two equations here. And I see in one of these my PCO2 is high, and over here I see that my PCO2 is low. If my PCO2 is high, what would that do to the pH? The pH would then be low. And over here, the pH would then be high. So what I like to remember, there's like a little mnemonic. It's called SMORE. So there's a little mnemonic. I'll put it over here. It's called SMORE. And this is kind of an easy way to remember it, where metabolic disorders, the pH and the bicarb move in the same direction. And then respiratory disorders, the pH and CO2 move in opposite directions. So that's kind of an easy way to remember that. So if you see the CO2 and the pH are moving in opposite directions, you know that it's most likely a primary respiratory disorder. Okay. Now sometimes the CO2 could be normal as well. And again, maybe that's a compensation mechanism that's going on. So again, just because it looks normal doesn't mean that there isn't actually a disorder present. Bicarb, use your same type of equation here. use your modified Henderson-Hasselbalch. pH is equal to the bicarb divided by the PCO2. pH is equal to the bicarb divided by your PCO2. And the same thing, we're not worried about the PCO2 right now, we're worried about that bicarb. How is that affecting the pH? So remember, SMOR, it's the same, or you can just use this equation, right? So let's say that I increase my bicarb, or I decrease my bicarb. What would that do to the pH? This would increase the pH, causing an alkalosis. This would decrease the pH, causing a acidosis. So you can either use this equation or use this little mnemonic to help you to remember that. All right, so I've determined the pH, if it's acidotic, alkalotic, or normal. I determined if my CO2 correlates with that pH in opposite directions, or if my bicarb correlates with that in the same direction. After I've done that, the next thing I need to determine is if there is a metabolic acidosis, then what do I need to go about and do? I have to determine my anion gap. Remember I told you that when there's a metabolic acidosis, you can have a high anion gap metabolic acidosis or a normal anion gap metabolic acidosis. So how did we calculate that? Do you guys remember? We take and utilize the equation. Anion gap is equal to, and we'll kind of abbreviate this, AG, is equal to the sodium minus the chloride plus the bicarb. And what this tells us is the amount, the anion gap is the amount of unmeasured anions, primarily organic acids. If the anion gap is less than 12, this is a normal anion gap metabolic acidosis. If the anion gap is greater than 12, that is an anion gap metabolic acidosis. And this is where you got to go and figure out what the cause of it is, which we talked about with those mnemonics over there. All right, the last thing we have to determine is the delta ratio. If someone has an anion gap metabolic acidosis, if they have an AGMA only, so if there is an AGMA, which means that their anion gap is greater than 12, then you have to do this delta ratio. And the reason why is they could have an anion gap metabolic acidosis with an underlying concomitant other disorder like a metabolic alkalosis or a non-anion gap metabolic acidosis. So you have to look for this to determine if there is a concomitant disorder. Okay? So how do we do this? You utilize what's called the delta ratio, and the delta ratio is a formula. And what you do is you take the anion gap that you measured. So let's say that you measured your anion gap. You calculated off of what you got from your BMP. So your measured anion gap minus the normal anion gap that you would have, which is 12. Okay? And so we'll just put here 12. You're going to divide that by your actual bicarb, particularly the normal bicarb. So your normal bicarb, it comes in a different range, and we'll write all those down in a little bit in a second. But your bicarb, it's going to be around 24. And then you're going to subtract that from your measured bicarb, what you got from your ABG. Okay? When you do that, you're going to get a couple different things. Okay, you're going to get some numbers. What you need to know is if the delta ratio there's three different things. You want to know if it is less than 1, if the delta ratio is between 1 and 2, or if your delta ratio is greater than 2. If the delta ratio is less than 1, that means that this is a pure anion gap metabolic acidosis. There is no other concomitant disorder present. If the delta ratio is greater than 1, but it's less than 2, that means that there is a mixed AGMA and NAGMA present. Okay? And the last thing is if the delta ratio is greater than 2, that means that there is actually not just an AGMA, but there's also an underlying metabolic alkalosis and an AGMA present. Okay? So, go through these steps one by one. Check the pH, correlate it with your CO2, your bicarb, based upon if it's going in the same bicarb CO2, opposite. If there's a primary metabolic acidosis, check your anion gap, see if it's elevated. If it is greater than 12, it's an AGMA. If it's less than 12, it's a NAGMA. If you have an AGMA, you have to do the delta ratio to see if there's a concomitant disorder based upon this equation, and whatever you get will tell you what that mixed combination is. The last thing I have to mention here is what some of these normal values are, because you're like, Zach, I don't even know what the heck normal is. So we know what the normal pH is, right? That's pretty simple. We can just mark that down real quick. Normal pH is 7.35 to 7.45, right? That's pretty straightforward. The PCO2 is somewhere between 35 to 45 millimeters of mercury. So if it's less than 35, that's low CO2, higher than 45, high CO2. Pretty straightforward, right? The bicarb concentration is usually between 22 to 26 milliequivalents per liter. And that's where I got that 24, is if you go between these two, it's 24, all right? And then just a quick review for anion gap. If the anion gap is less than 12, that is considered to be a normal anion gap. If it's greater than 12, it's an elevated anion gap. All right, so I think we have a basic understanding of how to kind of have a system to go through these ABGs. Let's actually go through some practice problems and try to see if we can figure them out. Now, the best way I think to truly understand acid-base disorders is doing practice problems. It really helps to kind of solidify what we learned. Now, the first one I give you, I'm kind of messing with you a little bit, but it's an important point to gain from this, okay? Let's start with our kind of step-by-step process. First thing we check is the pH. Is it normal, or is it low, or is it high? It's normal. You're like, Zach, what the heck? Already you're giving me a disorder that there's no actual disorder. Remember what I told you. Just because it's normal, pH does not mean that there's a primary kind of hidden abnormality present. Let's kind of still go through this then. Even though it is normal, the pH, is it on the upper limit of normal or is it on the lower limit of normal in this kind of situation? It's closer to the upper limit of normal. Let's make our lives a little easier then. Let's say that the pH, it's not high, but in respect to normal, it's on the upper limit of normal. My CO2, what's normal levels? 35 to 45. That's way beyond 45. So my PCO2 is high. What's my bicarb? It's 37. Normal is 22 to 26. It's way beyond 26. So my bicarb is high. Remember either the equation or that thing SMORE. If it's pH and bicarb are going in the same direction, it's metabolic. If the pH and the CO2 are going in opposite directions, it's respiratory. It's going in same direction, it's a metabolic disorder. And it's a metabolic alkalosis because it's a pH that's high. So it's a metabolic alkalosis. Now the next thing that you have to determine is, we didn't really talk about this a lot, but we kind of described compensation mechanisms. When someone has metabolic alkalosis, their pH is high, what do you try to do? Your lungs will try to do what? Slow down its breathing so that you retain CO2. And that's going to take some, it can happen over time where it can become a chronic kind of thing. But what happens is eventually you'll compensate for this. So look what happened. The person's CO2 started rising. And it rose up so much that it was able to bring the pH within the normal range. So this means it's a metabolic alkalosis with full respiratory compensation. Now, what would be a partial then? Because I know that's what you ninja nerds are asking. A partial compensation would mean that the PCO2 is still going up. It's high, but the pH is not within normal range. Okay? Boom, roasted. Let's move on to the next one. All right, first thing, check your pH. Is the pH high, low, or normal? Well, it's way less than 7.35. So in this case, the pH is low. What's my PCO2? It's way greater than 45. So the PCO2 is high. Bicarb, it's pretty much on that lower limit of normal, but it's still normal. So we're just going to say in this case, if you really want it to be specific, you could say it's low, but we're just going to put normal here. We're not going to even mess with it. We're just going to say normal in this case. So in that situation, use your kind of mnemonic SMORE. Look at the CO2. It's going in the opposite direction of the pH. The primary disorder is respiratory. Is it acidosis or alkalosis? The pH is low, it's acidosis. So this is a respiratory acidosis. Now the next thing that you could say is, okay, is there any compensation? What would happen if you were in respiratory acidosis? What would you do to your bicarb? Well, your pH is low, you would want to do what to your bicarb? You would want to kind of increase your bicarb, right? So that you could actually make the pH a little bit higher. In this case, we didn't really have any change within the bicarb. It's not really going up in that case. So since the bicarb isn't really kind of going up or changing in this point, then there really isn't a lot of compensation. So I would say that with this, there is no compensation with this metabolic, no metabolic compensation. So no metabolic compensation. Okay? And again, that should make sense where if your CO2 is elevated, causing the pH to drop, you should want to increase your bicarb, but it hasn't really gone up much. All right, next thing here. Let's go to the next scenario. pH 7.32, is it low or is it high? It's low. So my pH is low. Next thing I gotta look at is my PCO2. Is my PCO2 high or low? All right, so 35 to 45, it's technically a little low, right? It's not really low, but it's technically low. It's just 1 point under. So we can say that the PCO2 is technically low. The bicarb, 22 is the lower limit. It's way beyond that. So the bicarb is low, okay? In this scenario, these are going in the same direction. So if they're going in the same direction, that's a metabolic acidosis, okay? We know it's a metabolic acidosis. So let's put down here for right now, a metabolic acidosis. And remember what I told you, there is two types of metabolic acidosis. Elevated anion gap and normal anion gap. How do I calculate the anion gap? I have to take my sodium, 135, and subtract it from chloride plus bicarb. What does that give me? That gives me 12. So my anion gap in this situation is 12. What's the normal anion gap? Less than or equal to 12. So if I'm less than or equal to 12, that is considered normal. So this is a normal anion gap metabolic acidosis. Do I have to calculate a delta ratio? No, because it's not an elevated anion gap. Is there compensation? Okay, there's a low pH, right, due to a metabolic acidosis. If someone is compensating with a metabolic acidosis, what would you try to do? Breathe off CO2. If you try to breathe off CO2, what should happen to the CO2 levels? They should drop. Did it drop enough to bring the pH in a normal range? No. So it's a compensation, but it's not full. It's a partial respiratory compensation. So with partial respiratory compensation will turn me over and tickle me twisted. Let's move on to the next one. The next one here, pH 7.25. What is that? That's low, baby. What's the CO2? Well, it's 35 to 45. That CO2 is also low. Bicarb, that's low. Definitely. It's way less than 22. So go to my scenarios here. Bicarb is low. pH is going in the same direction. That's a metabolic acidosis. All right, we got another metabolic acidosis. We're on a roll. If I have a metabolic acidosis, I have to calculate my anion gap. How do I do that? 140 minus 77 plus 10. What does that give me? That gives me about 53, right? So my anion gap is 53, and whole mama, that is a big anion gap. It's way greater than 12. And so because of that, that is a high anion gap metabolic acidosis. With elevated anion gap metabolic acidoses, what do you have to do? Calculate a delta ratio. So if I calculate the delta ratio by taking my anion gap, 53 minus 12 divided by 24 minus 10, what do I get? I get a delta ratio of about 3. So my delta ratio is equal to 3. What did I say? If it's greater than 2, what is the problem? It's a concomitant metabolic alkalosis and anion gap metabolic acidosis. So this is mixed with a metabolic alkalosis. Now, if you want to determine if there is any respiratory compensation, you could check. And if we looked here, what would I expect? If the pH is low, okay, that's acidic, you're going to try to breathe off your CO2. If you try to breathe off your CO2, the CO2 should drop. Did the CO2 drop? It did. Did it do it enough to bring it into a normal pH range? No. So is it a full compensation or partial? It's a partial compensation. So if you really wanted to add that on, there's also partial respiratory compensation. This was definitely a beast. Okay, if you can get this one, you can probably get any of them. Okay? All right, next scenario. pH, low, high, normal. Oh, that's normal. right? It's 7.35 to 7.45, so it is technically normal. So it's a normal pH. For helping us to understand this though, is it on the lower limit of normal or on the upper limit of normal? It's on the lower limit of normal. So to make our lives easier, it's the pH is low. CO2, way greater than 45. So the PCO2 is elevated. Bicarb is usually 22 to 26. It's way greater than 26. So bicarb is elevated. Use the thing SMORE. If it's moving in the same, it's metabolic. If it's moving in opposite, it's respiratory. Definitely respiratory. And the pH is low, so it's a respiratory acidosis. All right, next thing, look at your bicarb. In a respiratory acidosis, your pH is low. What are you going to try to do? You're going to try to increase your amount of bicarb. You're going to try to retain bicarb or reabsorb more bicarb. Did we reabsorb bicarb? Yes, because the bicarb went up. Did it do it enough to keep the pH in a normal range? Yes. So is this a partial compensation or a full compensation? It's a full compensation because it brought it within the normal pH range. So respiratory acidosis with full metabolic compensation. Beautiful. Next scenario here. You have a pH that's equal to 7.28. That's low. So we have a low pH. The PCO2, 35 to 45, way less than that. So the PCO2 is going to be low. And then the bicarb is way less than 22. So that is going to be a low bicarb. Use your mnemonic SMORE. If it's moving in the same direction, it's metabolic, which it is. So this is a metabolic acidosis. What do we do with metabolic acidosis disorders? We calculate an anion gap. We calculate the anion gap by doing what? You take 129, subtract from 100 plus 11. What does that give you? That gives you about like 18. Then if it's 18, that's definitely greater than 12. So that is definitely an elevated anion gap metabolic acidosis. What do we do with elevated anion gap metabolic acidoses? We calculate a delta ratio. The delta ratio will tell us if there is a concomitant disorder. So we take 18 minus 12 divided by 24 minus 11, and that gives you about 0.5. So the delta ratio is less than 1. If it is less than 1, it is a pure, let's add that on there, a pure anion gap metabolic acidosis with no concomitant disorders associated with it. The next thing we have to determine is there compensation? If there's an acidosis, the pH is low, your body tries to compensate by breathing off the CO2, so it'll try to lower the CO2. Did the CO2 lower? Yes, it did. Did it do it enough to bring the pH in a normal range? No. So is it full compensation or partial compensation? It's partial. So there's also a partial respiratory compensation. Ninja Nerds, we have just completed our complete understanding of how to get through acid-base disorders.